That's great. So thanks everyone for coming for this talk today. So today we're going to be talking about the data accreditation and improvement scheme. Brief sort of introductions. My name's Max Keech. I'm a GP in City and Hackney, as well as one of the clinical leads at the Clinical Effectiveness Group. Shazia is one of our facilitators and is kindly going to be monitoring the chat for any questions, which we will deal with. And we also have Tom Morgan, who is the lead for Equip and GP. So in terms of what we're going to cover today, we're going to briefly cover a little bit about CEG and then what is going on with this scheme and what it is, and what you as practices need to do in order to sort of complete the requirements of the scheme, and then how CEG as well as others are going to be able to support you with tools to do that. And then we'll have plenty of time after that for questions. Okay. So briefly, sort of the Clinical Effectiveness Group's been working with primary care in Northeast London for sort of 30 years now, focusing on improving quality of care within Northeast London, and doing that with sort of with data and analysis. This is a sort of group of GPs, analysts, scientists, all based at Queen Mary, and we've built lots of tools over the years, including dashboards and searches and software, and as well as a sort of a heavy involvement in research and using that to inform the quality improvement. So, brief bit about the data accreditation and improvement scheme. So this is looking at sort of several factors. So it's a joint effort between CEG and the DAaIIS to help practices in producing good quality data and across sort of two major areas. So one of those is looking at consultation types and job roles, so that practices can see who is doing what work within their practice and sort of wider teams. And then also looking at non-medical needs of patients, particularly focusing on the core 20 plus, effectively the most deprived quintile of the population, so that practices can better support this more vulnerable group and for more targeted interventions. And we're sort of aware this is in the context of general practice is the busiest it's sort of ever been, and so if you have that good quality data, you can help you can sort of use the resources that you do have as cleverly as possible to provide care. So a little bit more on consultation data, particularly now that primary care is using a larger group of people within the multidisciplinary team because of the expansion of roles from PCNs and the additional roles. That's increased the number and different type of people that are working within general practice. So there's far more different types of people doing things within primary care than you would have had 20 or 30 years ago. And in addition to that, since the pandemic, we've sort of changed how we consult. So there is a lot more that is going on that isn't a simple GP face-to-face consultation. There is more telephone work doing, there's more other remote work going. So there's a huge new variety of different ways that care is being provided for practices. And part of the problem is that this isn't being recorded consistently within practices or between practices. And because that data isn't consistent and reliable, it's much harder to use. And if you can improve and standardize how you're recording that data, it's then much more usable, and you're able to use that to inform how your activity is going, what workload actually is. You can use that to look at pressure points that can then help with staff and patients to get a better service running. Examples of that would be if you've got good data, you'll be able to, for example, for your additional roles, you may then be able to look at where they need to be with in terms of estate planning. So what sort of consultation types are they going? What sort of room do they need? Do they need somewhere with an examination couch and scheduling, so that you have you're sort of maximizing the use of your estates would be an example of this. Big question that can come up with this is, does this affect your GP appointment data or GPAD, which we're aware has been in the news quite a lot of practices getting told they're not seeing enough face-to-face patients and various other problems with it. Short answer is no. This work doesn't affect in any way what is going through towards the GP appointment data. That's because this is looking at your different consultations and encounters within primary care. It's not looking at the appointment book, and the appointment book is what GPAD uses. So because we're not dealing with the appointment book, it shouldn't affect that work at all. If you do have issues with your GPAD data, you can contact the NEL facilitators to help with that. And in fact, this data is better than the GP appointment data in terms of trying to capture how much work you're doing, because appointment data will only carry what is booked into the appointment book, and there's a lot of work we know that goes on within primary care that doesn't really represent. So that's everything from a GP just calling a patient because they've seen an urgent blood test that they haven't booked in as an appointment, but they've had to record what they've done. Consultation data will pick that up.
Hold on, Max, if you just give it a second. There's somebody that's unmuted. If you wouldn't mind popping yourself. Thank you. Okay, go ahead.
That's great. Thanks. So consultation data covers a much richer environment of what general practice is doing. As I said, that can be some of the emergency work if you've got blood tests that are dealing with urgently, as well as online consultations if they're being dealt with without them being booked on as an appointment. When you're dealing with the online consultation, this will be picked up within your consultation and encounter data in a way that it doesn't from GPAD. So you can go and show, look, we're actually doing a lot more than what GPAD data is doing. And you can also then get a better idea of what you actually need in terms of support. Looking at the second aspect of this, we're looking at wider determinants of health. So this is, as we're aware, health is massively impacted by non-health related things such as social isolation, poverty, housing issues. These all can impact patients' health negatively when there's significant inequalities. And by improving the information that we have on these sort of wider determinants of health, you're able to pick up patients that are more at risk of outcomes, and you can help build in additional targeted support for these groups so that you can focus on them as a priority and priority for things. Quickly now, if you just have a quick break, if there are any questions in the chat at the moment so far.
Okay, so I'm just having a look. We don't have any questions currently. Does anybody want to pop one in now or jump on the mic? Okay, doesn't look like there's anything forthcoming at the moment, so you're happy to.
That's right.
Okay.
In which case I'll continue. So if we look next, we're just going to go through the scheme requirements and sort of the payment indicators for this. And there are three main phases involved within this incentive scheme. So phase one, this is mainly focusing on the consultation types and roles. So this requires several things. One, you need to sign up and you need to get the sort of staff training, which this is an aspect of what we're doing today, done. And then you need to complete the process of moving to the best practice when it comes to consultation types, and then job roles within the practice. The other aspect of this is looking at signing up, making sure you've signed up to Edenbridge Apex, and that you've signed up to the Memorandum of Understanding and Data Sharing Agreement with the ICB on that. In terms of payment outcomes for this, it's 10p per patient for total list size, and that can be paid after there's been proof of completion of this, which is a combination of that being the consultation type and practice roles being verified by CEG. So once that's completed, contacting us, as well as then the Apex side of that will be verified through Equip being able to know that you've signed up to the memorandums. For the Apex side of this, if you're having any difficulty signing up or you've got any questions or want any further teaching on how to use Apex as a tool to help with your practice, contact the Equip team and Edenbridge Apex, and that's the support email for Edenbridge on the slide. We're looking at consultation types. There are quite a lot of different consultation types that are currently being used, and what we've done is we want to slim that down to a sort of best practice so that we're using sensible consultation types that are specific so that we know exactly what they're showing. And we've created the fact file, which will be available on our website, and that includes which consultation types, which ones we want you to avoid using, and also how to go through the process of improving that within it. There will be two separate ones, so one will be set up for EMIS and one for System 1, because both have slightly different ways that you set up the consultation types. And the other important thing is with this work is make sure whoever is doing it has the correct privileges within the practice to do it, because a standard account that doesn't have the privileges won't be able to change this information within EMIS or System 1. What does this functionally look like? So what we've got here is a screen grab of an example of what happens when you're adding to the consultation for a patient. So if you've clicked to add a consultation, you'll get auto-populated your date, your time, who you are, where you are. Then you want to choose your type. And what we want to do is change that drop-down menu so that it has sensible consultation types in, like the ones you can see here, which is specific. So a telephone consultation tells you exactly what it is. It's a telephone consultation. And by using the correct consultation types, we then get better data. It's also good practice from a Mecoligo point of view if you can then show exactly how that consultation went happened, in whether that was in person, over the telephone, or something else. What I'm going to do now is briefly move to a live demo of the dashboards where this is shown. So these are the dashboards that Nell has currently produced using Power BI, which show how you what your data looks like, and you can look at it at a sort of entire Northeast London, which is what we'll do, but you can also drill down to your practice, and anyone can request access for this. You can access it with that link and request access to the primary care dashboards. There is a guide on how to do this, which Shazia will post in the chat, which Nell have produced, which just shows the simple how to set it up, and then the link there shows you how to access the dashboards directly. So I'm just going to switch to the dashboards now. So this is the dashboard that is for the consultation types. So you have the care encounters tool. So when you log in, if you've only got access to this, it will show you your primary care dashboards, and you want to move yourself to the care encounters dashboard if you want to look at this information. Now, currently, this is on the summary page. So this is currently just looking at the last year, and this is looking at all practices in Northeast London, all encounter types, because this is for a demonstration, so I'm not going to get into individual practices. Now, this is just a broad-based example. So if we look here, the key section is down here on the bottom right, so non-core encounter type. This is what is coming in from GP practices. So that bit earlier where I was showing you where you click your consultation types, this is what is showing here. Now, you can see the most common consultation type is an AccurX consultation. That's pretty understandable because that's what happens when you're using AccurX to send texts to patients. So that's why this is the largest group, and we know that's going to be the largest group, and there's nothing for practices to change with that because that's coming directly from AccurX. But if we look a little bit further down, the next most common type used across the whole of Northeast London is GP surgery. And this is an example of a consultation type that we really want to avoid because it doesn't give us specific information. So this doesn't tell us whether that's a GP surgery appointment which was in person, was that a face-to-face appointment, was that a telephone appointment, or was it something else? We don't know from that, and so you can't get that information back out retrospectively. So this is one that we'd want to avoid. Same for things like externally entered, because again, this doesn't provide information. But then an example of a useful one is something like this telephone consultation, which we know that that is a telephone appointment, and so we know that it's been done and it's appropriate. And exactly which ones we would prefer practices to use are set out in detail within the guide, and options for when there's one that you have currently used that we recommend you don't use. Moving on for this, we can look at roles. So this is another aspect of it, looking at who is doing what. And this again is giving you a breakdown of all the roles across Northeast London, and you can show this for just your practice. So for example, here, again, the right side, this is showing you the roles breakdown as they come from practices. So you can see the most common role across the whole of Northeast London is general medical practitioner, which again isn't surprising, and you can see they're doing about 9 million consultations over this year. And as you go further along here, you're getting to smaller and smaller slices of the pie. But depending on the practice, they may be larger roles. And what we want to do is make sure that these are all sensible roles that are appropriate for the person that's doing them, so that GPs are down as GPs, physiotherapists are down as physiotherapists, nurses are down appropriately as nurses, so that everyone is set up with the correct roles within a practice, and that you're not having people put in as vague roles that don't say what their actual role is. And again, exactly which roles we'd like people to use for different types are set out within the best practice guide. And if there are any that you find that aren't listed there, you can contact us and we can look for alternatives. And with that, does anyone have any questions at this point?
Yes, so we've got one just a little bit higher up. It's just regarding the payment. Have we covered that section in full yet? Or will we come up to?
So we can cover payments in full a little bit later. We've only looked at phase 1 so far, so we will go through the phase 2 and 3 payments a little bit later on, and we can recap them at the end as well. But broadly, so far with phase 1, the payment is 10p per patient on list size, and that is paid once you've done all of the approved parts for phase one. So you don't have to wait until the end of the year. If you've signed up, if you've got your Apex stuff sorted, if you've got your consultations and your roles all sorted, and you've evidenced that, we can then move forward to getting that towards payment. So that doesn't have to wait until the end of the financial year, but can be paid after the work is all done and been authorized.
All right, so just to contextualize that, we had a question from Paradeep Chibber, who said, can I ask, is that an annual payment essentially? So if a practice had a list size of 5,000 patients, would they earn £500 annually? The answer is no, it's just a one-off payment that, as Dr. Keech said, will be paid once you have completed phase one. And I'm just going to pop down. We've had multiple requests for the slides. Yes, we will send out the slides following the session. And then we've had a question from Carol Taffinder saying, is there data from this that says how many Flories are being sent out to do reviews, please? Does it have specific data on Flories in the dashboard?
So
shall I answer that, Max?
Yeah, great, Tom, thanks.
So I think it's a very good question, Carol. And we've got some issues with AccurX at the moment in that their stuff all of their stuff tends to look the same as whether it's inbound or outbound, and whether it's a Flory or an SMS message. So, but there's basically the NHS Digital are kind of playing catch up with this, and there's a new spec coming out for all suppliers who have an API. This this interface with DAaIIS or system one.
Caravan, how much it is.
Sorry, is there somebody unmuted?
Emma wants to come
we
over.
Are privy to your conversation.
Right, caravan trip.
Oh, there we go. Yeah, they're muted now. Go ahead, Tom.
So at the moment, Carol, I can't say like definitively whether you could identify a Flory versus any other bit of AccurX activity, but what I know is that it's coming down the line. So all of the suppliers of online consultations and anything that interacts with the clinical systems is going to need to be able to differentiate kind of inbound, outbound, and the kind of mode of it. So if it's not there at the moment, it's coming down the line. As soon as we can pass it out in the observation table, which is where all this stuff tends to fall into on EMIS or TPP, we'll be able to split it out. So if it's not, I can have a look. I'll take away and have a look at that, and I'll drop you a line about that, Carol. But if it's not there at the moment, it will be at some point in the future, near future, I hope.
Thank you, Tom. So currently that's a no. Carol, I will just point you to the back end of AccurX, and I do believe it does quantify how many messages you're sending out there. It's been a while since I've had to use it frequently, but it's worth exploring the back end to see actually if it does tell you how many Flories you were sending out. We did have a couple of other questions. Where do we get the best practice guide? So that will be distributed after the session. It may not be later today, it may be sort of this week or early the next, but that's coming out to you as soon as we've finalised a few details there. And then can you send the sign up setup guidance? So again, that will come following the session. Right, that's all the questions. Max, if you want to carry on.
That's great. So next we'll be looking through phase two, and phase two has sort of two major components to it. So part one is relevant to your whole list size. So this is looking at indicators that have been frequently collected previously. So this is data on ethnicity, whether a patient is a carer, their language preferences, their communication preferences and contact preferences. So this is data that people are probably aware of and have collected before. For example, ethnicity within historically was in IIF, although no longer. And this has a sort of threshold of 95% coverage for all groups. And payment on this is 3p per patient, based again on registered list size, and that is then paid at the end of year one. And there are you are able to exception code patients for this, because there is a sort of an obvious awareness that some of this data, such as ethnicity, is sensitive, and patients may refuse to disclose that data. There's then part two, which is looking at those wider determinants of health that we mentioned earlier. So there's four main indicators on this. So there's looking at social isolation, the patient's health literacy, whether they have any housing issues, and whether they have any problems with employment or they've got financial issues. And this is a scaled payment. Now, this doesn't cover the entire list size. So this is based essentially off Core 20 Plus, which is based off the 20% most deprived regions, and that's within NEL rather than UK wide. So that is the primary cohort for this, but it also includes newly registered patients from the 1st of October of this year. That is then where the payments are based. So that is the payments are per patient on that cohort. And this is a tiered and cumulative payment system. So there is a payment based if you manage to meet the 25% threshold, which is 6p per patient in that cohort. If you get over 46%, that's then 9p additionally. And then if you get over 71%, that's an additional 15p. And these are cumulative. So you get the 6p once you get to 25%. If you then get to 47%, for example, you get the 6p plus the 9p. And if you're beyond that into the 70s, it's 6p plus 9p plus 15p. Now, this can be achieved over 2 years. So you may do really well and get to 75% in the first year, in which case you'll get the whole payment at the end of year 1. If you only manage to get to, say, 40%, you'll get the payment for that in the year 1. If you then manage to improve that up to 75% by the end of year 2, you'll get the additional payments that you'd be entitled to for that. And there aren't any penalties associated with this, but there is no exception coding available with these indicators. These are obviously can be sensitive topics to discuss because people's financial situations, their housing and everything else can be very sensitive topics for patients. So we are providing some training for this. There is some initial training that we are providing, which is tomorrow afternoon, the 20th of July, which Shazia will post a link to the sign up for there. That's currently funded for City and Hackney and Waltham Forest. We are trying to get additional dates sorted, and those will be circulated via the bulletins once we have those confirmed. And Shazia will post the link for sign up in the chat for the session tomorrow. We'll also provide our standard suite of templates and searches. So these templates should already be available within your systems. They should be part of a library item, and they should be available on all templates under the wider determinants tab. If you are not seeing those templates there, please do let us know, because those should have now been published in all areas of North East London. We've also created an AccuRx Florey. So this is targeting the part 2 of phase 1, those wider determinants questions. It contains a 4-part questionnaire which asks about those 4 indicators. This can be sent to patients to respond directly, and if they fill it in, it will fill in the correct code into their patient record, which is an appropriate code for the payment indicators. The link to download this will be in the best practice guide that we will be circulating, as mentioned, by the end of this week or early next week. This can be customized for practice needs and will need some editing so that it's clearly showing that it's from your practice, but the questions and the coding is then all available for you to download and use. That's the end of the sort of summary of phase 2. Do we have any questions that we'd like to go through now?
Yes, we've got a few questions. I'm just going to scroll up. Right, so how do you code all of this data? Again, we are going to cover this in the next section. Max?
Yeah, so in terms of how do we code the wider determinants data?
Yeah.
Yeah, so that is, if you use the templates, that will automatically put the correct codes into the patient record. And if you've used the AccuRx Florey, those will automatically put the codes into the patient record. So if the patient fills in the survey from the questionnaire, it will put in the appropriate codes that would result in payment.
Thank you. Then we've got another question. Have you been speaking to the online registrations team about getting this information that comes into practices? Obviously, patients can now register online via a separate portal to their actual GP website. So have we been in contact with the team? So actually, part of this information, apart from, I'm going to call phase 2 part 1 and phase 2 part 2. Phase 2 part 1, this is likely information that you're gathering already around communication preferences, around carer status, around ethnicity. So it should already be in there, and every practice is using a different method of sign up, but I think it's worth exploring getting in contact with them. I think we did try to reach out earlier, but I'll just pop that down. But essentially, there's nothing in phase 2, part 1 that should be very different to what is already on your registration forms. And then, are there any CEG searches for phase 2, part 1 and part 2? Max, do you want to answer that?
Yes, we are developing searches that are specifically for phase 1. For phase 2, part 1 and part 2. So yes, there will be searches available.
Okay, then we've got another question around the payment. Is the payment, if you have asked the questions, say for example, if we're asking the question around isolation, or only if the patients are actually isolated?
So the payment is around having a relevant code within the record. So that doesn't mean the patient has to be isolated. It means that they've answered, that the question has been answered. So either they have said, I am socially isolated, in which case a relevant code on social isolation is put into the code, or that they are not socially isolated, in which case a negative code which says patient is not socially isolated is coded. And that negative is then also readable and is relevant for payment, yes.
Okay, we've got another question. Is this 25% of your total population or a specific population included within this?
So this population is not the entire practice list size, no. This is based off core 20 plus, so it's looking at the 20% of patients that are most deprived within Northeast London. So that is a number that will vary depending on what your practice list looks like. That is the bulk of this cohort. The second part of this cohort is all new patients, so not just the most deprived that have registered after October 2023.
Thank you. Now we've got a couple of questions around the specific templates. What are the template names on System 1 and what are the CEG templates called? So just off the top of my head, these will be referred to as the wider determinants of health. In EMIS systems, this will not be a standalone template, I think, apart from in one borough. But actually, it's a template tab in most of your templates, definitely in your LTC template, and that will be called the wider determinants of health. So hopefully that answers both of those, but we will refer to them in the guide so you know exactly what you're looking for. And again, Abul Hassanat, I hope that's answered your question. What is the name of the CEG NEL accreditation template? Janet Butcher has said, what evidence do you require for phase 1, or do you pick this up from Edenbridge?
Yeah, so good question. So part of it is picked up through Edenbridge. So once you have, part of this requires you to sign up for the data sharing agreement with the NEL ICB. So they will so we know once you've signed that up that we have seen that Apex has been downloaded, seen that the data sharing agreement has been signed and the data is being shared. So that part is able to be done via Equip. The other side of it, which is looking at consultation data and role types, we will ask you to send to CEG verification that that's been done, and that will be through a form of showing clear screenshots showing that the consultation types are available are those from the fact file best practice guide, and don't include ones that we want avoided, and the same for job roles. So there are two parts to that. One part does need sending through, which will be the consultation data in job roles. The Apex data will be verified with Equip who are using it.
Thank you. And then I think you may not have mentioned, Max, but for System 1, we're aware that for EMIS, you're able to change those job roles yourself. But for System 1, it's a slightly different system. So we'll be asking you for separate evidence, which is that you are communicating with the TPP team in order to get any roles that are incorrectly allocated changed. So that'll be a slightly different way of evidencing for those practices using System 1. Then we've got another question from Gosha. Will you provide practices with the examples of the Flories? We will provide you with the Flory. So we have built that already, and what we'll do is we'll use the Flory share link, so you'll be able to access that and add that to your AccurX system locally. Is this in Flory already? Yes, hopefully that has just been answered, but once we distribute that link to you, that will be available. We've had another question about the name of the template. Again, that should be the wider determinants of health. And in EMIS, that is a separate tab. And I believe it's the same in System 1. Sorry, not a separate tab. It's a tab within your templates already. The Flories, what are they called? Actually, what have we called it? It's a good question.
So I believe it's called the wider determinants Flory. I can double check the verification and it will be available. What happens when you're sharing a Flory is when you click on the link, it will download it. It will give you the title. It will give you all of the template with it. And that will be pretty much oven ready and good to go. All that will need editing is it currently says in parts of it, for example, at insert your practice here, and obviously don't send it with insert your practice here, put your relevant practice name in it.
Thank you. Will there be searches available for us to monitor our own progress? Yes. Yes, these searches will be made available to you all. Are these templates set up for TPP practices? Yes, so the idea has been to make this available both for EMIS and System 1 practices at the same time. Right, we did have a hand up earlier, which seems to have disappeared, so hopefully that means we've answered the question, but there are no more questions in the chat box for now.
Great. In which case, we can carry on. So then final phase is phase 3. So this is essentially a reaccreditation visit, and this is at the end of year 2. So there was that question on, is this an annual payment? Which the answer is no, it was a year 1 payment, but there is a second year payment. What this requires you to have done is this requires you to have done all the bits from phase 1 and them all still to be in place at the end of year 2. So you did your work on improving your data, you carried on with the right data, and you've still got the data sharing agreement with Edenbridge Apex. That's all still in place. Tick. And then the other part of that is you've carried on doing that, but you've also managed to get to at least the minimum threshold of phase 2, which is that 25% threshold on those wider determinants data. So you don't have to hit 50%, you don't have to hit 70%, you just have to get yourself over the 25% to be eligible for that accreditation payment in year 2 and to have done all of the consultation data work. That is another payment which is exactly the same as phase 1, which is 10p per patient based on the entire registered list size. So it's very similar. It's effectively the same as phase 1, but you just also have to have hit that baseline phase 2 target as well by the end of year 2 to get that payment. Okay. So in summary today, what we've gone through is we've gone through what the data accreditation and improvement scheme involves, why we're doing it, all of the key payment indicators for this, as well as how both CEG and Equip and Edenbridge can help you hit those targets, and the timelines for this. In terms of additional support, we have you'll have your local facilitators, and if you do have any questions about this scheme, you can get in direct contact with them, and if they're doing any site visits for you, this is exactly something that they can also provide support with at those site visits. Okay. Thank you very much for listening. Does anyone have any further questions?
So we've just had a couple of questions come in after the last round. So when will the searches be available? The answer to that is imminently. Essentially, the person who has been working on searches is off currently, which is why we haven't got that oven-ready package ready for you. But as soon as they're back, we will be looking to distribute those as soon as possible. And do you know if practices have been paid for phase 1? Nobody has been paid for phase 1 yet because we haven't gotten the best practice guide out to you yet. So that piece of work hasn't been completed or evidenced. So that's just to make you aware of that. And then can you confirm payment for phase 2? On sign up, it says 33 pence per patient to be confirmed.
Yep, that's a really good question in terms of the phase 3 payment. That is because this is a cumulative payment. So when we are looking at that, as we were saying before, there's tiered payment. So you've got that initial 6 pence per patient within the cohort. You can then add your 9 pence per patient to the cohort on that, and then you can add the 15 pence per patient for that cohort. That gives you a total of 30 pence per patient within that cohort. There is then the additional other part, the part 1, which is for the whole patient list, which is 3 pence per patient of the total list size. That is where that 33 pence number has come from, but that's actually a lack of clarity because it is the actual total maximum available is 3p per patient total list size. And then if you hit the second part, there's 30p per patient of the cohort of patients that are included, which, as I said, is based on that most deprived 20% quintile and the new registrants from the 1st of October 2023, rather than it being the entire patient list size. So it is not 33p total for the entire list size. It's 3 pence for the total list size for part 1, and then there is up to 30p per patient within the cohort that is available in part 2, but it's not 33p per patient total list size, no.
Thank you. Right, just popping back up. Yes, the recording will be made available after the session. When will the best practice guide be available? It was supposed to be out prior to the meeting, I thought. Well, that was the aim, but sadly there's a few more I's to dot and T's to cross. So again, we are hoping to get that out to you as soon as possible. Somebody has said Toyin will be able to help me interpret the data. Absolutely, Toyin, if Toyin is your local facilitator, she'll be able to help you interpret the data. And then have we estimated the hours of work typically needed to implement each phase for scheduling purposes, e.g. for a list size of 5k to 10k? I will immediately...
Shall I come to that?
Yeah.
Sorry.
Yeah, go for
it. So when we were looking at the scale, the scale of the incentive scheme and the kind of budget that we had to play with in order to roll it out, we had a lot of conversations with London-wide LMCs to sort of understand kind of what would be in scope and what would be out of scope based on the budget that we had for the entire of the incentive scheme. So our colleagues in the LMC sort of went away and did some of that work, and we adjusted what was in scope for the incentive scheme, and also the value of particularly the middle part, the part around the wider determinants of health in line with the advice that London-wide LMCs gave us. So we actually took a few bits out of the incentive scheme, and we put the value of that middle of phase 2 up according to the likely workload. I mean, I think that what we were hoping from this is that a lot of the work can be automated through the use of the Florries and the searches, and that will then free up capacity for the kind of more of the fingertip work for the harder to reach patients. So I think part of this is because it's a sort of brand new area. For example, you can't make assumptions about access to digital, for example, in certain population groups and based on things like deprivation. So that's the sort of element of the unknown here. So essentially, we stacked the incentive much more around the phase 2 because that's where the most work needs to be done. Phase 1 is relatively light touch really in terms of the workload that's required, and it's a sort of do once and then forget it sort of payment. The accreditation visit is just to look and see that the systems are in place. So the bulk of the incentive sort of follows the work, but it was adjusted in line with advice from the London-wide LMCs.
Thank you, Tom. And then we've got a last comment there. Can we have a firm date, please, for the best practice guide? We need to plan for this work and can't do that. Absolutely agree. If you're anything like me, it's very difficult to figure out what you're doing in terms of planning the work without actually seeing it physically in front of you. And I'm hoping that the searches and the guide will be able to do that for you. But like I said, just a couple of T's to cross and I's to dot, and then we can get that out to you as soon as possible. But that is absolutely a priority. Okay, we've got another comment. I can't find the name of the Florey on AccuRx. That's because we haven't shared the link yet. But once we've got all the resources available to send to you afterward, then you will have that available. What you'll do is you'll click on the link and it will give you the option to add that particular Florey to your local AccuRx account. Okay, are there any other questions? Will the targets be adjusted then for this failure to give us the specs in a timely manner? The specs are out. That's the thing. It is just this best practice guide that needs to come out. But if you feel that this is really going to impact you, we can have a conversation after this session if you feel that this delay is really going to impact your achievement in this. But like we've said, phase 1 has a payment attached to it, and phase 2 has a payment that can be attained, the full scope of which can be attained over the next 2 years. So it's very unlikely that you will be able to or that you will not be able to due to this sort of blackened time in the first year. You've got 2 years to achieve the full payment across your group for phase 2. Right, we're getting lots of email addresses. I've said it already in the chat, guys. If you've signed up to this via the form, which admittedly some may not have, if you've signed up for this webinar via the form, we've got your email addresses and we'll be sending out all of the resources to you.